now we move to the next talk by Dr. Prakash, sir. Sir is going to talk to us about considerations for cataract surgery in uveitis patients on immunosuppressants. Dr. Prakash is the CMO and HOD Vitreoretinal Services at Comtrust Eye Hospital, Calicut and Talasheri. Over to you, sir.
Thank you, Divya. So we all know cataract is a common complication of chronic and recurrent uveitis. Cataract can be a result of the inflammation itself, or it can be due to topical steroids or systemic steroids. Topical steroids, you should bear in mind that more than one drop a day is cataractogenic. And if you look at the causes for visual loss in patients with uveitis, 40% is due to cataract and is the most common indication for surgery in uveitic patients. And if you look at the whole number of cataract surgeries happening, 1.2% is due for uveitic cataracts, and this entity is more surgically demanding and has less predictable postoperative outcome. If you look at the indications, the absolute indication is a phacoantigenic uveitis, where the lens particles itself worsen the inflammation, or it can be due to visually significant cataract in an eye with good expected visual potential and well-controlled inflammation. Both are very important. And if you have an impaired fundus assessment in a patient and you are suspecting that there is something going on in the posterior segment, some form of inflammation is going on in the posterior segment, those cases also you will have to undergo cataract surgery quite early before you have an adequate control of inflammation. And of course, when you have a combined surgery required like a retinal detachment in a uveitic patient. So if you look at the outcome, on the whole, vision of 6/12 or better is achieved in about 60 to 80% of the patients, of which if you look at the subtypes, anterior uveitis has the best outcome with 90 to 95% achieving more than 6/12, but this is, mind you, this is without JAA included in this study. And when it is posterior uveitis or panuveitis, the success rate drastically reduces to less than 60%. VKH has about 60 to 68%. And Behçet's has got the worst among the lot with about only less than 20% achieving 6/12 or better vision. So why do you require immunosuppressive in a patient with uveitis? The most common cause is an uncontrolled inflammation in spite of going maximum steroid dose. So if the patient is intolerant to steroid, then you may have to start immunosuppressives quite early. And there are certain disease entities which require long-term immunomodulation. Steroids cannot be used more than 3 months, so those cases you will have to switch the patient to immunosuppressives. And what has immunosuppressives achieved for us is what is known as zero tolerance to inflammation. So that can be achieved only with immunosuppressives. And also it has changed the outcome of cataract surgery in severe form of uveitis. JAA alone, if you look, in the pre-immunosuppressive era, only 22% of the patient achieved 6/12 or better vision. And post-immunosuppressive, this has changed to almost 70%. So this is one disease entity where immunosuppressives have changed the outcome of cataract surgery drastically. So the challenges involved in doing cataract surgery before uveitis in a patient with uveitis is, of course, control of inflammation, as I told you earlier, the zero tolerance, drug dose modification, how will you modify the dose of the drug, and what is the optimal surgical procedure for a particular patient. And in cases with posterior segment pathology, whether you should do a combined vitrectomy or phacoemulsification alone followed by vitrectomy as a second procedure, and what is the best adjunct therapy, whether it is posterior subtenon, intravitreal or implants, and IOL or not, whether to use or not in especially in younger children. So coming to the disease status, it's the most important thing before you decide on cataract surgery. It can completely change the outcome of cataract surgery in uveitic patients on immunosuppressive. So ideally you require 3 months of remission before doing cataract surgery, but this is not true in case of Behçet's disease alone, because Behçet's, it is known to have the post-operative recurrence in Behçet's is significantly related to the frequency of ocular attacks in the 12 months before cataract surgery. So ideally 12 months or at least 6 months remission is required when you are planning cataract surgery in a Behçet's. And preoperative evaluations on the slit lamp, you should not ideally have even flare, but at least no cells should be there. And OCT is compulsory because your fundus view in these cases is usually limited because of posterior synechia and all other things. So OCT will bring up new things which you didn't see at all in the pre-op evaluation. So that is compulsory. And FFA and ICG in select cases, especially in those eyes where anterior segment inflammation alone does not give us a clue what is happening to the uveitic status, especially like cases like VKH. So here you always look for on angiography the hot discs, the filling defects, capillary bed inflammation, and in ICG also you can see these swelling defects. If these are present, that shows there is some activity going on. You have to wait before you do cataract surgery. And UBM is very important in patients whom you suspect hypertony. So the pre-operative regimen is you have to start them on intensive topical and oral steroids, and oral corticosteroids usually started 3 days prior to the surgery. The dose is 0.5 milligram per kilogram oral prednisolone, that is half the dose that we usually use, on top of the immunosuppression that is happening. And once cataract surgery is over, slowly taper 5 milligram per week until 20 milligram, and after 20 milligram taper only by 2.5 milligram per day, per week. And or in 1 or 2 weeks you can, depending on the activity that is happening. And FLAIR can be used as a good biomarker to monitor activity of uveitis. Sometimes you may be forced to do a cataract surgery in an active uveitis. This happens when the lens becomes suddenly intumescent and AC shallows. Those cases you have to give intravenous steroids, either methylprednisolone or dexamethasone, before taking up for cataract surgery. And nowadays, more and more we are using preoperative or intraoperative adjunct local therapy like intravitreal triamcinolone and Ozurdex, and studies have shown that this is equally efficacious as giving oral steroids. This can be done either preoperatively 1 or 2 weeks before surgery or intraoperatively. Both it has got good efficacy. And intraoperative challenges include small pupil, which can be managed with various techniques. Pupillary membranes can be there. BSK is a common issue. If it is very bad, you can do an EDTA chelation before taking up for surgery. Peripheral anterior synechiae and posterior synechiae, and always release the peripheral anterior synechiae before you release posterior synechiae. In case of uveitic cataract, you can use an viscoelastic device and swipe, push and swipe along the angle to release the posterior synechiae, then only release the peripheral anterior synechiae. Choosing the IOL, usually prefer the hydrophobic IOLs, foldable IOLs and clear corneal sections, and the adjunct intracameral dexamethasone or Ozurdex or intratricot can be given in these patients to prevent recurrence of uveitis. And when to combine with vitrectomy. One indication is when you have dense vitreous membranes, which going to prevent your postoperative visual recovery. Also, vitreomacular interface disorders are very common in uveitic patients like VMT, ERM, macular holes. Those cases definitely will require a combined surgery. And cyclitic membrane on UBM, if it is present, always do surgery combined with vitrectomy, otherwise you are going to end up with hypertony. And uncontrolled inflammation, especially in case of pars planitis, you can combine with vitrectomy to achieve better inflammation. And in cases where you suspect going to have hypertony or preoperative hypertony is there, you can combine with vitrectomy and put silicone oil. So what is the risk of hypertony in a patient undergoing cataract surgery? If the IOP, pre-op IOP is below 8 mm mercury, always think of possibility. Seclusio pupillae with a normal IOP, that's also high risk. And if you have an apparent phacodonosis without evidence on analysis, and on B-scan is always important in these cases. Diffusely thickened choroid or choroidal effusion, if you see on B-scan, then always you can predict the possibility of hypertony. So just this is a case example where you have a vitreomacular interface disorder, that's a vitreomacular traction, and an epiretinal membrane. Also there is a disc traction on a patient, lady with panuveitis. And you can see that this lady has undergone TRAB also before, and we have done a clear corneal, avoiding the bleb, a section was made. Sorry. Yeah. So this is a very small pupil, so there is a pupillary membrane. The membrane is cut with the cystitome and then removed with our retinal forceps. And peripheral anterior synechiae, you have to completely go under the iris and release it completely. And any pupillary expanding device can be used in these cases, but here I am using a B-hex ring. This is quite very found to be very useful in these cases. And it's the rexis, when you do, it has to be at least minimum 5 millimeter, not less than that, because capsular phimosis is a big complication after uveitic cataract surgeries. So phacoemulsification is performed, and the post cortical wash and visco wash has to be meticulous. You don't want to have any retained cortical matter. This will again trigger inflammation. And then foldable hydrophobic intraocular lens is preferable in these cases. I have removed the ring. The rim can be kept till the end of vitrectomy surgery also, but I had removed it in this case. If I have to use a tamponading agent, there is a risk of it coming into the AC, so I had removed it because there was sufficient pupillary dilatation. The 25 gauge vitrectomy was done, and you can see the detached hyaloid, which was trimmed all around the fovea, leaving the foveal portion attached, because pulling that directly might result in causing a iatrogenic macula hole. So it is peeled along with the ILM and along with the internal limiting membrane after staining with BBG. So that reduces the risk of creating a macula hole. So the postoperative complications, the biggest postoperative complication is uncontrolled inflammation and cystoid macular edema. Cystoid macular edema is you will have to hike your topical steroids as well as the systemic steroids. Exudative RD is a very common complication in this case of severe uveitis. Again, you will have to hike steroids, or you will have to give IV methylprednisolone in these cases. Epiretinal membrane raised IOP as well as decreased IOP is a complication. PCO is very common. Pupillary membranes will happen. There will be pigment deposition as well as giant cell deposition on the surface of IOL. This can be removed by doing an YAG capsular YAG polishing of the anterior surface of IOL without causing pitting. Capsular phimosis is a common complication, and optic capture as well as subluxation of IOL can have. And pediatric eye in uveitis is a big challenge by itself. JAA is the most common complication where most common scenario where you will have immunosuppressive in a pediatric eye. Here there is relentless inflammation in the postoperative period in most of these cases. PCA, Sinec, pupillary membranes, optic capture, all these are very common. And it's important that you do a primary posterior capsular rhexis along with anterior vitrectomy. You can use a tricot, which will help you visualize the vitreous better. Also, it will give some amount of perioperative inflammatory control. In all children below 8 years, it has to be done. And suture all wounds. Don't leave any of the ports or main wound open in pediatric eyes. And IOL, most of the people believe it is better to avoid below 2 years. And always you can give the results of giving intravitreal tricot or as well as Ozurdex is very promising in pediatric eyes. So to conclude, in this form of severe uveitis on immunosuppression before planning cataract surgery, the most important thing is you should have a good control of inflammation, or anticipate all these postoperative complications, and managing this well will give you usually a good visual outcome. Never deny cataract surgery in a uveitic patient, because it can make a lot of life easier for these patients. Thank you.
Thank you, sir, for that excellent and wonderful talk. All the questions we came prepared for have already